Thank you. Good morning, everybody. Thanks for having me. I'm Hansel Otero. I'm a pediatric radiologist here at CHOP. And we're going to start this morning talking about the Botswana-UPenn partnership. And as we have 8 speakers, I'm supposed to take less than 30 seconds introducing each. So the first one is Farouk Dako, radiology faculty here at Penn and the director of the Botswana-UPenn partnership. Farouk, all yours.
Awesome. Thanks so much, Hansel, for the introduction. Hansel is my co-director of the case competition that Glenn spoke about from the CHOP side. Thanks. So my name is Farouk Dako. I'm the director for the Botswana-UPenn partnership. I have all these different organizations up here because it is indeed a partnership between University of Pennsylvania, obviously CHOP, the Ministry of Health in Botswana, and University of Botswana. And we have been in Botswana since 2001. Initially, during the height of the HIV pandemic, we were invited by various stakeholders, including Merck Foundation, Gates Foundation, to really come and help out with the crisis in Botswana. At the time, there was no medical school. And so as you can imagine, we had to set up a whole office to be able to process grants, pay staff, hire people, and things of that nature. Over the years, as you can see, funding sources have evolved. We had a big PEPFAR support sometime from 2006 to 2016 that focused more on women's health, informatics, and we're able to expand beyond just the HIV care. And then we had a period of COVID-19. As you can imagine, things slowed down a bit as far as travel, and now we're looking to the future, right? And so I've been in Botswana for about 6 months at this point, understanding what the goals are in the country. And right now, they're focused on 3 things that I have up there. They're working on universal health coverage, health system strengthening, and digitizing of their healthcare system. And so we want to be strategic partners in these core areas. And I would like to tell you guys that business is booming in Botswana. Grants are actually flowing. More people are back visiting. Every other week we have a guest from Penn, CHOP, and from other institutions. And so things are really, really looking up. And so I just wanted to talk a bit about one vision, which is this idea of making BUP a center for excellence in various things. I'm a radiologist focused on AI and informatics. So understandably, this is something that I think we can start with, which is, what can we do beyond just, our traditional grants? How can we coalesce, as Glenn said, have all these efforts happening in Botswana coalesce into a strategy to be able to improve their informatics support there, but also, have it be a resource for our researchers at Penn, a place where you could extend your research to, a place where we could potentially train and develop a workforce that can serve us here as well, while creating jobs over there. And really, like I said, given their focus on health system strengthening, how do we start to measure our impact and strengthen their healthcare system? And so, I just have this diagram up here just showing BUP as a hub for bidirectional exchange of workforce, of ideas, as a hub where we attract other people in the region to come work there and help actually make their dreams come true. And so that's really it for me. Just a quick overview of what we've done and one big vision that we have moving forward. I hope I kept the time. Thank you very much.
I was told that Farouk was the one that was going to take extra time, so now we did great. Thank you. All right, the next speaker, another good friend, Andrew Steenhoff, pediatrician in the ID at CHOP, and the medical director for CHOP Global Center. Andrew.
Thank you, Hansel, and thanks for the opportunity to share with you. I'm going to speak about the power of partnership today to reduce infant deaths by 48% in Botswana. So let's start with the problem, and we're going to start our story in Botswana. You can see where Botswana is on the map, a country about the size of Texas or France. And we're going to start with Henry, and you can see a picture of Henry leaning over a child there. Henry was a global health fellow who joined us at CHOP and at Botswana UPenn in August of 2009. He started working in Botswana's second largest town, Francistown, and what he noticed is that he was seeing a lot of very sick children, and you can see a picture there of one of the kids that Henry would have seen. These children were coming in with severe gastroenteritis, vomiting and diarrhea, and despite what Henry and all the colleagues were doing in Botswana, a number of these kids sadly were dying. So much so that in the gastroenteritis season, each year, there'd be at least one child a day that would die. And Henry said, what on earth is going on here? Why are these kids dying? What's the cause? And so with his mentors in Botswana and back here at Penn and CHOP, Henry took on a research project in 2010 in his second year of fellowship. And he looked at all these children who were being admitted in Francistown and in Gaborone, and he looked at the causes of gastroenteritis. And what he discovered, you can see there, maybe not surprising to us now, 15, 16 years later, but 78% of the sickest children who were coming in with gastroenteritis had rotavirus. This at the time was new news for Botswana. So what was the solution? Well, fortunately, as part of Henry's mentoring team, he worked with Dr. Lueto Majani, pictured, and Dr. Margaret Mokomane. Dr. Lueto Majani is a famous pediatrician in Botswana who'd worked in the Ministry of Health and was working at the University of Botswana at the time. And Dr. Margaret Mokomane was the leader of the National Health Lab. And so what Henry did with his mentors and with Dr. Majani and Dr. Mokomane is he met with the Ministry of Health. And wonderfully, thanks to the influence, particularly of Dr. Majani and Dr. Mokomane, the Ministry of Health listened, said this is an issue, we need to deal with it, and they brought forward the rollout of the rotavirus vaccine in Botswana. And this was rolled out in July of 2012, making Botswana one of the first countries in Africa to roll out rotavirus vaccine. So what was the impact? Well, Leslie Anane, pictured here, a CHOP ID fellow with a strong interest in global health, worked with the CDC and colleagues at Botswana, Penn, and CHOP to work this out. And you can see in the graphic, which is shown from her paper that was published in Clinical Infectious Diseases, the impact. On the y-axis, we have number of deaths in a year. And then on the x-axis, we have the pre-rotavirus season in black. And you can see there that each year for the 3 years that were looked at, 40 children were dying at the 4 hospitals that Leslie looked at. And then in the first year post-rotavirus vaccine, that the death rate dropped by 53% in these 4 hospitals, and the second year by 43%. So an incredible result. And the overall summary of her paper was that post-rotavirus vaccine, there was a 48% reduction in rotavirus deaths in children under a year. This represents 20% of the population of Botswana, so we can times the numbers by 5 to get a country impact. And this has led to the WHO, amongst other papers, to encourage rotavirus rollout across the African continent. So in summary, partnerships have power. But you can see at the bottom of the slide who is involved with this: the Botswana UPenn Partnership, the University of Botswana, the Ministry of Health of Botswana, McMaster, who did the testing, the CDC, who helped with epidemiology, and CHOP. And so my message is simple. If we've got the right people in the room, powerful partnerships can save lives. Thank you.
Thank you, Andrew. Making Derek's job easier when people are on time. Next up, we have Michelle Johnson from Physical Medicine and Rehab, and also a Faculty of Bioengineering and Mechanical Engineering at Penn Engineering.
Hi, everyone. Michelle Johnson here. I was a product of kind of the Center of Global Health, kind of like trying to expand faculty involvement. In 2016, when I first, I was interested in doing technology-assisted rehabilitation and seeing how technology could bridge gaps in rehabilitation in Botswana. And I started the Rehabilitation Robotics Lab, and I wanted to know where where actually could I do global health work? And I circled to Center for Global Health, and CFAR, Center for AIDS Research, had seed grants. And I had always been interested in non-traumatic brain injury like stroke. And so the idea was, how do I translate that into Botswana? One of the key things I found out immediately was that Botswana, the stroke survivors in Botswana had HIV, and that was something that I was not familiar with. And so I got a sponsorship from the Center for Global Health to go out to Botswana to just try to understand what was happening in rehab, and that's kind of what I began. My first experience in the country was just mind-blowing. You know, I've actually never been to Africa. I'm Jamaican born from the Caribbean, so I'd never been to Africa, and it was kind of, whoo, this is great. But that also led me to see that there were really gaps in care in terms of rehab. Now I'm a PhD, not an MD, and I've always been working in this technology-assisted rehab. I also did some investigation to discover that the numbers of physical therapists, the number of occupational therapists were really low, and how can we leverage their skill so that they can treat the number of people that were having disability. I also found out that most people after stroke were unable to actually access rehabilitation because of the shortage in staff, and they would come in and they would get discharged immediately from the hospital, and they would head home without really any intense treatment. So that kind of began my saga, and then now I was faced with the fact that stroke survivors had HIV. What does that mean? And that actually caused me to pivot in a line of research that was looking at HIV, people with HIV only, people with stroke only, people with HIV and stroke, and looking at how our technologies could assess their motor function and their cognitive function. And that actually spurned research that I later was able to get an NIH a grant to continue that research. We now have actually robots in Botswana. We have a collaboration with my colleague, Makiel Maikutlo Kibetsi, who is a physiotherapist in Botswana, who is the co-PI of the lab, started a rehabilitation robotics lab there. We ported some of our technology. We were able to then do some work in the community in both Gaborone and in Mahalape. And I do have posters out there that kind of talk a little bit about where we are. When it began in 2016, I came back and talked to my chair. Dr. Dillingham has a poster out there. Hey, PM&R needs to be there. But I'm not an MD, so how do we get PM&R doing more? Because there was no physiatrist at all in the country and I was like, what? No physiatrist? What's going on? And then I met a trainee Cuban physiatrist, and she said that Cuba would send a physiatrist once a year. So it took a little while, but then Dr. Dillingham went over, and he does prosthetics and lower limb research. And then he went over and got a lay of the land and started kind of doing his work there. And then that created an impetus for him to recognize, hey, you know, there is a place for rehab here. And since then, there's been now an official PM&R involvement in Botswana. And I'm pleased to say that they've now sent over a couple of physiatrists to kind of get the lay of the land. And I'm hoping with the rehabilitation lab that's there, that we can do more and more in Botswana. And hopefully, if you're interested in kind of learning about what we're doing, the technology-assisted work, you can come and just check out the flyers of our team. Thank you.
Thank you. I appreciate you going at it without the slides. All right, next off, we have from the Department of Infectious Diseases, Bohari Loabile.
Good morning, everybody. I am neither Robert Gross or Robbie Schnall, but I've had the pleasure of working with them over the last couple of years on a smoking cessation trial in Botswana, the Thotloetso trial, which means encouragement in Setswana. Okay, so people living with HIV are actually 2 to 3 times more likely to smoke than than the rest of the general population. And this isn't any different in Botswana. About 50% of males living with HIV in Botswana smoke tobacco. Smoking cessation is not really a thing currently in Botswana. The only available medication for smoking cessation is nicotine replacement therapy. This isn't something that is available within the government healthcare system, and so people would have to buy these things out of their own pocket, and it's probably a little bit cost prohibitive for the average individual. And even within the government healthcare system, there's really no available counseling that is happening. So Robert and Robbie came together and designed a novel intervention that is derived from depression treatment. This was a behavioral intervention, and they used prior depression treatments because of the link between HIV and depression, as well as the link between depression and smoking. And they used this in combination with MAPS, which is a problem-solving, also behavioral intervention that was used successfully for adherence to medications. Individuals would undergo 5 sessions and would also get homework, and this would be delivered by telephone. So they had a pilot trial that looked like there would be preliminary efficacy with this intervention, and so they went ahead with the Thotloetso trial, which was a randomized control trial where individuals were either randomized to BAPS, which is this novel intervention, versus standard counseling. And individuals were then assessed at various weeks, with week 24 being the final outcome of whether or not individuals had stopped smoking. So to look at the baseline characteristics of the individuals who were involved in this trial, 651 individuals in total were recruited and randomized between these 2 arms. Individuals were middle-aged, reflective of the people who smoke in the country. More than 80% of these people were men living with HIV. As you can see here, they had very high depression scores. About 60% of people recruited had high depression scores, and 20% of individuals had hazardous alcohol use. So week 26 is where they assessed abstinence, and this was assessed if an individual at week 24 reported that they weren't smoking anymore. They actually had a CO confirmation, a breathalyzer test that tested to see if they had been smoking. What was surprising in this trial is that about nearly 40% of all individuals who were involved with this trial actually stopped smoking. And a little bit of context, in the global north, you expect with behavioral interventions only about 10 to 15% of people to stop smoking. So about 40% of individuals within this study stopped smoking, which was really high. Also, I wanted to highlight the session completion rates, about 80%, which is quite high for randomized controlled trials, and there was no difference in treatment efficacy by sex or depression status, which is something that we were looking to see. So in conclusion, both behavioral interventions were really effective. Anecdotally, the standard counseling was easier to deliver, and they had slightly better attendance rates and slightly better quit rates. This work is going to be presented to Botswana's Ministry of Health and other stakeholders next week. We hope to help them with developing guidelines for smoking cessation within the public healthcare system. And we think that probably an intervention that is telephone-derived is going to have the most success. Future work that Robert and Robbie are looking to do is bringing medications for smoking cessation. Cysteine is a plant-based, cheaper alternative of varenicline, and they're hoping to do a trial that does medication in combination with counseling in Botswana. Thank you.
Thank you, Hadi. All right, next up, we have another good friend, colleague from CHOP with many superpowers, including good mentor and matchmaker. So, Liz Lowenthal, everybody, please.
Good morning. I don't usually talk with a script, but it's the only way I think I can stick to 5 minutes. So I've been working in Botswana since 2004, and there are many stories that I could tell in these 5 short minutes. So I've decided to try to put you in my shoes from 22 years ago and take you on a little trip, sharing one ongoing project and the prior work that inspired it. So picture this. You're a young pediatrician, just a few years out of training, and you sign on to spend 1 year in Botswana helping to catalyze the rollout of the continent's first national antiretroviral treatment program. Botswana has invested heavily in the treatment of its citizens, but there are thousands of children who are waiting for diagnosis and treatment. Many of them come in looking like this. They're chronically ill, and many are truly suffering. But the medicines are nothing short of miraculous. And within a short time, you have happy, healthy children thriving on antiretroviral therapy with their happy, healthy parents. With the privilege of playing a role in successes like these, you can't stand the idea of leaving Botswana after just 1 year. And so you stay on for more years. And you stay on until your family drags you to Philadelphia. But when you come to Philadelphia, you stay connected with your colleagues in Botswana and many of your former patients. You get training in epidemiology because Penn has a great program for that. And together with your friends in Botswana, you begin to study some of the questions that are important for improving the lives of children with HIV. Then, fast forward a few more years, many of the children that you quickly grew to love in Botswana continue to thrive. But too many of them, as adolescents, are deciding that they no longer want to take their medicine. As a junior research scientist, I got my first NIH grant to explore the reasons why many of the adolescents were beginning to struggle, how we could best identify those who were likely to struggle before their problems occurred, and how to best support them. One of the common reasons for not taking medicines really surprised me. Some adolescents who were born with HIV were telling us that they could never succeed in school, and as they failed out of school, they lost hope for their futures. We knew that children affected by HIV frequently have cognitive challenges, struggling with issues such as less working memory, slower processing speed, and more difficulty sustaining attention. When these challenges aren't recognized, the children are labeled as lazy or poorly behaved and blamed for their performance lagging behind their peers. But with identification of their strengths and weaknesses, these young people can be supported to maximize their strengths and progress towards meaningful long-term goals. Thus, the Ntimoha study was born. Ntimoha is a Setswana word that has many meanings. It means cognition, but it also means know my needs, motivate me, take me seriously, know me inside and out. All of the phrases that you see here in this word cloud. It's challenging to understand a child's cognitive strengths and weaknesses in a setting where there aren't yet culturally adapted and validated assessment tools that can be administered by available professionals. Thankfully, by the time my colleagues in Botswana and I became aware of the need for tools to better assess cognition among HIV-affected young people in Botswana, Dr. Ruben Gurr, pictured on the top in the middle there, and his colleagues at the Penn Brain and Behavior Lab had already been working for decades on developing a computerized neurocognitive battery, or CNB, that could allow for understanding of how an individual's brain works through game-like online evaluations. Through a grant in collaboration with Dr. Cobb Scott, pictured below Dr. Gurr, we were able to culturally adapt and validate the Penn CNB to allow for its use in Botswana. Now, with the support of the government of Botswana and the Penn Global Engagement Program, we're working with the Ministry of Child Welfare and Basic Education in Botswana to train and deploy a group of local psychology and educational professionals who are using the Penn CNB and will now be able to assess students who are struggling in schools throughout the country. Using implementation science and quality improvement methodologies with our colleagues in Botswana, our next steps are to pilot and improve strategies aiming to support as many children with neurocognitive challenges as possible throughout the country, helping them to reach their potential. We're excited to see where this partnership goes next. Thanks.
Thank you, Liz. Let me use this one. Thank you, Liz. All right, let's see. Okay. Next, we have Greg Reason from Medicine and Epidemiology.
Hi, everybody. Thanks so much for the opportunity to speak today. Thank you. So in 2025, there were 10.7 million TB cases and approximately 1.2 million TB-associated deaths. And we often think of TB as a disease that is an infection. They present and they can be treated. But what is underappreciated is approximately 60% of people, over half, have chronic scarred lungs resulting in impaired lung function after treatment completion. And the idea that patients with post-TB struggle is really illustrated by the fact that when you look at TB patients who've completed therapy successfully and they're compared to comparable community-based controls, there's approximately threefold increased hazard of mortality. And one data set that I think is really shocking is that when we think about TB as a treatable infection, they're done with their treatment and their treatment is complete, approximately half of all health loss due to TB is from post-TB sequelae. So it's something that sticks with people long after they're treated. So there are an estimated 155 million TB survivors living in the world today, indicating this is a very important public health problem. So as the medical director for Philadelphia Tuberculosis Control, I've seen hundreds of TB patients over the past several years, and I can tell you that I worry far more when a patient comes in about whether or not their lungs are going to heal than whether or not they're going to fail microbiologically. Microbiologic treatment failure in tuberculosis in our setting and in many places around the world, including in Botswana, is very rare, whereas destroyed and impaired lungs is very common. So one thing I ask clinically is who's going to get better? So this is pre-treatment and post-treatment scans from 2 patients. So this patient was treated for TB, and for whatever reason, this huge thick-walled cavity looks a bit ominous when you start treating them. It's almost completely gone away, leaving a small scar. Whereas this patient had bilateral disease, has some aspects of their lung heal, but is left with cavitation and bronchiectasis. That is a bad place to be because this is essentially an open portal to the world and contributes to chronic inflammation and post-TB lung disease. So in my research life, the questions I ask are very clinical, but use translational methods to try to solve these. So which patients have non-responsive TB and why? We're trying to define phenotypes of TB that are focused more on treatment response and less on initial presentation. So we're using translational methodologies to try to sort this out. So can you tell when patients present why some patients get better and why some patients don't? So in our studies in South Africa and now in Botswana over the past decade, we're using translational approaches to try to characterize, for example, lesion maturity. This is not an FDG PET-CT scan. That PET scan is radio labeling immature type 1 collagen. So we're trying to look at specific lesions to say, is there differences in lesion maturity which may predict whether things are going to resolve? Because fundamentally the question is, if you could identify patients who aren't going to get better when they start TB treatment, with just TB treatment alone, the other patients should be enrolled in clinical trials of adjuvant therapies. But what therapies would work? So we're using sputum transcriptomics comprehensively on over 250 patients in Johannesburg, South Africa, with longitudinal assessments over time to try to find immunologic profiles that predict response to therapy and non-response to therapy and identify candidate therapies, which are hopefully already FDA approved. This is my final slide. So what are we learning? there are different phenotypes of response. So this is FEV1, it's a pulmonary function metric that's associated with survival. This is time, and we're following patients from treatment initiation to 6 months after treatment completion. If you're further down here on the Z-score scale, your lung function's worse. So not everybody is the same. In fact, they're shockingly different. Some patients never really have a problem with lungs. I don't know why they tolerate their TB in a different way than others, but we're trying to figure it out. Other patients have loss of lung function and some have healing. So we hypothesize that these will have different immunologic profiles and may require different therapies. And if we can identify who they are at the outset, we'll be able to propose clinical trials. We're also learning about important phenotypes of TB that I think are somewhat underappreciated. So this is a complex graph, but I think everybody can see there's more blue on the top and more red on the bottom. So what we're comparing here is HIV-infected patients, which are on the bottom part of the circle, to HIV uninfected patients on the top. More red lines mean they tend to disseminate inflammation from their lungs to their circulation. So there's positive correlations between biomarkers in sputum and blood. Whereas with HIV uninfected patients, the correlations tend to be negative. We hypothesize this is a phenotype associated with spilling inflammation systemically, chronically, perhaps due to impaired pulmonary function, epithelial barriers. So in summary, our research is trying to take the power of all the translational research potential that is all over University of Pennsylvania and bring it to this important question about TB to try to focus on the types of outcomes that people really care about, which is whether or not they can breathe, live, and function a healthy, long life. Thank you.
Thanks. And we're down to the last two, and we're almost on time. It's always up to the last couple speakers because they are between people and their morning coffee. So Stephen Avery from Radiation Oncology.
Good morning, everyone. Let me stay on time. So I'm a professor of radiation oncology. I'm also director for the Global Radiation Physics in the Department of Radiation Oncology. So today I'm going to talk to you about building an architecture for global oncology. So global oncology is not a technology problem. It's a systems problem. If we look at the persistent disparities that we hear, we always hear three forces that continually come up: workforce, fragmentation, and financing. So it's not that we don't lack innovation, we lack integration. So what would integration look like? Education builds workforce, workforce expands clinical capacity drives research, research enables innovation, innovation shapes policy, and financing is what sustains and scales the whole system. So this is not just a theoretical model. We're actually are doing this right now at the University of Pennsylvania. So this is one example of integration, the Ampere project. Ampere is a 12-week mentored research experience. It includes year-round global mentorship. We use VR-enabled training. And Penn serves as a coordinating hub for global medical physics workforce development. This is not a project. This is infrastructure. Infrastructure that connects education to capacity, capacity to research, and research to global alignment. But there's one other piece that we have to consider, and that's the financing gap. Over $100 billion of capital that goes from the diaspora to the continent each year. A large portion of this money is used for reactive cancer care, for medicines, for travel, for emergency treatments. But it's fragmented, it's unstructured, it's not pooled. Let me leave this question with you. But if we could structure, let's say 1% of that $100 billion into a structured capital for cancer infrastructure. So this is not about separate initiatives. It's about alignment. Workforce development, research engagement, policy alignment, financing architecture. Not separate projects, just one architecture. Because the future of global oncology will not be built project by project, but system by system. Thank you.
And if you've been paying attention, you have a lot of questions, and we'll have opportunity to engage at the break. If you have not been paying attention, you will have more questions, maybe of lower quality, but you will still have time to engage during the break. Last, we have Hans-Peter Koller from the Faculty in Demography.
Demography, yes, democracy.
From the School
Well,
of
support
Art and
democracy
Science.
as well,
It was
but
a
I'm
different school.
going to focus on demography in my talk and not get into trouble by talking about something else. Thank you very much for inviting me. Thank you for supporting global health at Penn, for supporting our project in particular. In addition to Botswana, where Penn has a long-standing partnership, Penn has another one that is very long-standing, 25 years and counting, and that is to Malawi. Malawi is strikingly different to Botswana. It's one of the poorest countries on the continent, and this project is different by starting in a different corner of campus. Rather than seeing global health as a biomedical problem, we see it as a social science problem. That social science is an important part to understanding and improving the health of individuals globally. So this project started off in an interest in fertility decline, lots of HIV research. I'm going to talk today about its interest in aging. And importantly, this has also integrated from a social science perspective to a very strong school connection to the Perelman School of Medicine, to the Center for Global Health, but also genomics, cardiovascular disease, and other ones. So the reason is about aging, right? So the world is getting older, and the question is, what do we know about aging? And we know a striking amount of how individuals get older and these things in relatively affluent countries where population aging is concerned a major issue. We know strikingly little about aging among the poorest individuals in the world. But this is where some of the most rapid aging comes about. And so we've been trying to leverage this study that's been going on for 25 years to develop a fairly unique low-income country aging study, where we've been following the same individuals for roughly about 25 years. We've collected 14 rounds of data on them. This is a population-based sample. We're just going up on a data collection for their grandchildren at the very moment, and try to push the frontier in what we know about population aging by taking a life course perspective on getting older, understanding health at older ages, bringing in social science data. We have the only longitudinal data on cognition in a low-income country in Africa. We expanded this cognition work last year to allow the diagnosis of dementia to, for the first time, be able to do research diagnosis of dementia, understand cognitive decline dementia in a life course perspective. We've collected dried blood spots. We've done them genetically sequenced. We've computed epigenetic clocks. We hope to do, in a strikingly different context, what is the benchmark for contemporary aging research in high-income countries by integrating social science with biomedical areas, life course perspective to do social science or biosocial aging research. And we hope to do this in Malawi, where kind of income levels are roughly on $1 a day, to kind of truly innovate and change how individuals age. And on first hand, it's an observational study. We want to understand this. And secondly, we want to then obviously inform policy. We're fortunate that we have, over these 25 years, built up very, very strong relationships to our partners in Malawi. There's a very close collaboration between Penn and partners in Malawi. We're grateful that we have a visitor coming to the Center for Global Health this summer. And I invite all of you to kind of engage with us in research on health, aging at older ages, taking a social science life course perspective, using these data, right? 25 years I've been involved from the very beginning in this, because I think we can make some very distinctive, unique contributions to an understudied phenomenon in a context like Malawi. Thank you so much.
Well, that's it for the session. Thank you very much.